Hey everyone, welcome to the Straight Talk Physio podcast with your hosts, Dr. Andrew Junak and Dr. Craig Giambattista. On today's episode, we're going to talk about the cause of pain and why the cause of your problem may have actually nothing to do with where it hurts. So we're super excited to launch this episode. It's something that me and Craig see pretty often in practice. This is a concept that we call referred pain. And the way that we tease this out is through our detailed assessments. And that's how we figure out what is actually causing the pain versus where the pain is actually located. So we're going to get started by having Craig talk a little bit about the definition of referred pain, what it is, what it means, and why it exactly happens. Go ahead, Craig.
Got it. Yeah, like you said, excited to get started about this one. So I like to keep the definition for referred pain nice and simple, and then kind of give a little more detailed explanation as to why it happens. So when I define referred pain, it's typically pain that is perceived at one location that is different than the actual painful site or origin. So the big question I get, people come in and say, well, why does that happen? That doesn't make any sense to me. You know, it hurts right here. What's going on right here? So we typically take a step back, and I like to give two theories. And what you'll kind of notice in this podcast, along with a lot of other medical stuff, if you tend to listen and follow to it, it's our best theory. So I'm not claiming to know exactly what's happening, but based off the most current evidence and stuff going on, I think this is our best guess. So the way I typically describe it is the way our system works is a lot of information goes from your limbs, trunk, peripheral system. It sends some messages to the spinal cord. The spinal cord sends it up to the brain. The brain processes it, and then it spits something back out for how we feel something. So a lot of times with referred pain, there is a kind of a pain center up in the brain where all this information is kind of coming. And we're kind of thinking that it gets so much input from so many different places, sometimes so fast, that sometimes it can't actually identify the actual specific place it's coming from. So sometimes that brain center might get a little bit confused just because there's so much stuff getting thrown at it at the same time. Something else we kind of think is that some things that cover similar places in the body, they kind of connect to the same spot in the spinal cord. So even though you might get some sensory receptors or those nerves that send information that maybe are in your chest and in your upper arm and maybe in your forearm, maybe all of those places giving information connect at the same spot in the spinal cord. So when it sends the information up to the top, again, the brain might be a little bit confused because there's similar things kind of connecting at the same place. So the big example I like to use here is when you're having a heart attack. Everybody knows the signs and symptoms of a heart attack. Your heart is not working. Your heart is right here in your chest, but now all of a sudden you're getting arm pain, burning in the side of your neck, burning down into your arm, maybe even into your hand. So why does that happen? It kind of goes back to what we just talked about. You have some good sensory receptors in the skin of your arm, and your shoulder and your neck, and they kind of converge. They go to the spinal cord in the same spot that those sensory receptors that go to your heart. So sometimes you're getting all this information from two of the same places, and your brain might register that as the pain is coming from the arm. It's actually coming from the heart there. So a little detailed response, but I think that's the most simple way we can try to explain this sort of phenomenon. And it's a little confusing because it kind of is. So it's definitely a little hard thing to grasp, but I think that using examples like that can be helpful. So Drew, I don't know if you have any examples or any ways you explain it to patients, or if you have any thoughts on that one.
You know, I think the best thing or the best way for me to explain it is where it hurts isn't always the cause. You know, that I try to keep it as simple as possible when I'm working with patients. And usually the patients understand that. And the reason that they understand it is because they've maybe seen another provider that has, or they've received some sort of treatment, or they've been, trying the do-it-yourself method with YouTube videos for shoulder pain. And they've done 30 different exercises, no difference, and they still have the symptoms. So they get it. A lot of times patients understand, it hurts here, but when I press on that spot, it doesn't make it worse. It actually feels good when I, roll it out, but the pain just kind of sticks around. So at the end of the day, I think patients tend to know like, hey, something's going on. It hurts right here, but my neck also feels tight, or the back of my hamstring is bothering me, but my back's tight too. It's kind of weird. So a lot of times this type of referred pain can sort of mask itself to providers and sometimes even patients. And it's our job to kind of bring that out and use our assessment to find it. Do you find this pretty often in practice, Craig?
I would say I see this all the time. And part of the podcast today is we're going to go through some of these common things. And I think it's important to do that because a lot of times people come in and they get a little bit worried that if they're having shoulder pain and it's really coming from the neck, or if it's neck pain and now they have numbness and tingling in their hand, that can be a strange sensation, and that's weird because if you have no medical training, it makes sense that if a spot hurts, that's where something is going wrong. So if that's not the case, if that's new information to you, then it can, of course, you'd be a little bit nervous to say like, well, that doesn't make sense. Like, am I in some serious trouble here? And I think you said it perfectly. It's our job to explain that to the patient and doing a good detailed assessment and kind of proven and say, hey, if we do these movements, it causes your familiar pain. This is kind of how we can address it.
Yep.
So I would say I have this talk pretty regularly with patients. And I think if we hit on some common places today, then it'll help our listeners out to say, you know what, I relate to this. This is something that's happened to me. So
Yeah.
I don't
Well,
know if you want to start us off here, if there's like a common spot you see, or if you have anything else to say to that.
Yeah, well, before we jump into it, I do want to make note that I think that sometimes it takes time to do an assessment that screens out some of these other body areas. So before we jump into like the actual referred areas of pain, it takes a little bit more due diligence than just jumping to, oh, the shoulder hurts, I'm just going to assess the shoulder. You want to start with the neck and then move down to the shoulder, and then sometimes even down to the elbow, or you want to look at the thoracic spine. You kind of need to look at the whole area. And I think with kind of the state of healthcare and where healthcare is at right now, a lot of providers don't have the time to do that sort of an assessment. If you think about your surgeons, these guys, you might see your surgeon for 5 minutes during an appointment. You might spend 10 minutes with a medical assistant or someone who's taking your blood pressure, getting a history from you, getting some basic information. But then, the surgeon comes in, they might only have 5 or 10 minutes to see you. And in that time frame, they're trying to use the information that they have and then decide if this is truly a shoulder problem or a neck problem, or a back problem or a hip problem. So I think sometimes this stuff gets missed. It gets missed pretty frequently. I see it in practice a lot. But starting off with one of the most common ones that I see, I would say neck pain that radiates into the shoulder blade, or into the side of the arm or down the arm is something I see pretty commonly. What happens is a patient will come in, they'll say, it hurts in the side of my arm or it hurts down in my shoulder blade. I've done all these shoulder exercises. I took a lacrosse ball to it. I took a foam roller to it. I went to somebody and they scraped that spot. I've had dry needling done in these different areas. Lo and behold, I have them move their neck around or do a couple different things. I start to question them about their neck issue, and it starts to come out that this was actually a neck problem all along. So a lot of things that they were doing were not neck related. And so they were just kind of trying to get at the symptom of the problem, but not necessarily the cause. Craig, is there any other ones that you see with the neck pretty frequently, even with like nerve patterns and stuff?
I would say nervous system involvement is a big one. I'll have people come in all the time and say, you know what, my pinky finger and my ring finger are tingling. It gets worse when I do these various movements. And I say, you know what, that makes sense. I think it's coming from your neck. And then they give me the weird look and they're like, well, what do you mean? It's just my hand is just tingling here.
You mean it's not carpal tunnel or?
Oh, the classic carpal tunnel. They're sleeping with the funky carpal tunnel brace, which works. I'm not bashing the carpal tunnel brace. Like, I recommend it. It's good, but it's that connection, like you said, is super hard to make. And I think talking about what you mentioned before with the time to do assessment, I think it's important to hit like it's when I see the best buy-in, or when I help people kind of understand this sort of thing, is if I can do a movement at the neck and it causes symptoms down into the hand, then it's like, okay, this
Bingo.
makes sense. It takes a little explaining. Like I kind of go back to what I was mentioning before, saying that, there are various structures in the body that kind of converge and give, information at the same place. And we have that talk, but it's way harder to have that talk if you can't do, some movement and it causes symptoms somewhere else. I think that's way helpful.
Yeah.
But I would say as far as the neck is concerned, outside of what you talked about, the big thing is, neural referral down into the arm or hand. And it could be numbness, tingling, burning,
Hmm.
all irritation that comes from the root of the nerve, which was kind of the root of the problem, which is in your neck.
Yeah.
So any other upper quarter stuff you tend to notice that's, outside of the neck, any peripheral stuff?
Yeah, I would say shoulder pain is another big one. The rotator cuff can refer as far down as the elbow. It typically doesn't go below the elbow. It'll stop at the elbow, but it'll go down the side of the arm. Most people know that the rotator cuff is located like kind of deep in the shoulder. There's 4 different muscles. One's deep. It's really hard to put your finger on it. And then there's 3 other ones that are a little bit more superficial, and they're over on the scapula. And those muscles there, a lot of times when people think about it, they think, oh, well, my rotator cuff hurts. It's going to hurt in the back of the shoulder. But most of the time, the rotator cuff actually refers to the side of the shoulder, and then it starts to move its way down the arm. So I'd say that's probably one of the more common ones. I know a frozen shoulder, people who have extremely limited range of motion, and their shoulders kind of locked up. That's another one that can refer to the front of the shoulder, down the side. It can refer to a whole bunch of different areas. Into the upper trap. You can almost feel it like neck pain sometimes. So there's a number of different things, definitely in the shoulder, that can do that. Is there any more you can think of?
I would say the biggest one is well, I'll use the patient language here. The rotor cup is
Rotary cup.
the rotary cuff. The rotary cuff is always on the outside. I couldn't tell you how many times people come in, they grab the outside of their shoulder and say, "What is here?
Yep.
What's going on here?" Kind of pointing to that.
Or they Google it and they say, "Oh, I have deltoid pain." That's
Yeah.
another.
Oh, yeah. The deltoid muscle for sure. So with that one, the big thing is I'll say, okay, well, let's do an exercise that really stresses the rotator cuff. And
Yep.
then we'll try a couple and says, okay, there's outside of the arm pain. And that's kind of where we help make our decision making there. So,
And not to jump ahead too far, but when people go the Dr. Google route, because the first thing that people do is, hey, something hurts. I'm going to jump on Google. I'm going to say, oh, it hurts on the outside of my arm, outside of arm pain. And then Google will say, like, it'll bring up either a muscle, or it'll bring up one of the more common diagnoses that could happen there. But that's a lot of times where a patient might get an idea. They'll go to Dr. Google. Dr. Google will give them some information, and then they'll go to YouTube. They'll YouTube some videos on how to fix it. And then they're wondering why it didn't get any better. And then they'll say, well, maybe I just need surgery. So sometimes patients will go find a surgeon. But most of the time, I'd say 95 to 99% of the time, if they go see somebody and a thorough exam's done, they'll find out that pain actually wasn't being caused by those structures in the first place. So
yeah.
Moving on, Craig, there's another body part. And this one, I mean, we could do a whole podcast episode on referrals from this area. This is probably the most common area of the body that we see pain referrals to all different regions. Would be the lower back and the sacroiliac joint, or like the joint that involves your pelvis and your tailbone. So do you want to start us off with kind of what some of those referrals look like?
Right. And this is definitely going to be a tough topic here, like you said, because you can talk about this I think me and you could talk about this for hours and hours. But for today, I think the important thing is let's just get some basics in, because this is something that I see all the time. I'm sure you see this all the time. And that's people come in and they say, I have a little bit of back pain, but now I have a lot of pain in my right leg, or I have pain down my left leg, or I have pain down both legs, what is going on. And I think a common lumbar, especially SI joint referral, and I tell people that it's such a highly innervated and complex structure that we're not going to try to get too hung up on saying what exactly, anatomically is going on, but just be okay with the fact that your low back can refer pain anywhere down into your feet and your toes. And don't be too worried if something like that happens, because it's pretty normal in the world in the world of low back pain. So as long as you kind of are okay with that, I think that's like a good starting point. I don't know, are there any specifics that you get into or stuff you see or, specific ways you like to explain that one?
Yeah, I would say that, kind of going back to where it hurts isn't always the cause. And that's why I do with my assessment, I'm looking for certain spots, because knowing that these areas refer to these other spots, I kind of have a like predisposition to look for them and seek them out before I move on with my exam. And I would say that the upper part of the lumbar spine tends to refer more so to the front of the thigh and the groin area, which is very similar to hip pain. So people who have true hip pain usually will have pain in the front of the thigh or in the groin. But if you're moving someone's hip around and you're not recreating that pain, then there's a chance that it could be coming from the upper part of the low back. Another common area that we see is the lower lumbar. So the lower part of the back will actually refer to the side of the leg. It can refer to the back of the leg, and then it itself can also go all the way down into the foot. This could be sharp shooting pains. It could be dull, achy pains. It could be burning. It could be numbness. It could be tingling. I mean, it could be any sort of symptom. And that's why I tend to throw people for a loop, or even from a patient standpoint. A really interesting case that I had a couple weeks ago is a patient came in and said, I have pain and it's in my hamstring, but I didn't do anything to pull my hamstring, or I didn't do any sort of activity that, like, there's no one incident. So in my mind, I'm thinking, well, maybe this person doesn't have a hamstring strain. I push on the hamstring, I do some of my testing, and it doesn't hurt at all. I do a couple other tests, and it turns out there's a little bit of nerve tightness on that side. I press on the patient's back in a certain spot, and then boom, they feel it down in their hamstring. So this stuff it's pretty elusive, and if you're not prepared to see it, then you just won't see it, but it's seeing you. You know what I mean?
Exactly. Yeah.
So, with that being said, is there any other low back or SI pain referrals that you can think of?
I think another one, and again, I think it's important noting that I would consider this stuff like sometimes can be on the rare side,
Yeah, some of them can be.
Some of them can be a little more on the rare side. And I would say my favorite one to pick up on is lower lumbar, upper sacrum can actually refer pain to the heel or maybe even the arch of the foot. So people are coming in, I have an Achilles problem, I have plantar fasciitis, all this other stuff. I've been going through treatment for months and months. Nothing's getting better. When, no one took a look at the low back kind of deal. So sometimes it can even be little stuff like that. It doesn't have to be some huge, big gross referral, like saying the entire back of my leg hurts. It could be as simple as, I got this weird spot in my heel. It doesn't feel quite right. And then, finally someone says, well, have we taken a look at your low back? And that can kind of, stir some symptoms up. So it doesn't have to be, huge symptoms, which I think is kind of what we're used to sometimes when we talk about this referred pain.
Yeah. I think, actually, I have a goofy story about that. When I was at my first job, at my first hospital job, I had a patient who had a plantar fasciectomy, had rehab with a physical therapist. And then they had a second plantar fasciectomy, or I think the first one was a release, and then they had a plantar fasciectomy. Then they came to me and I screened their spine, and actually exactly what you're talking about, pressed on a spot in their back, and they felt it right in their heel. So this patient unfortunately had two surgeries that probably could have been very easily avoided. And neither of those surgeries addressed her pain. Super, super sad to see, but this stuff does happen. And it's just, it happens, unfortunately. Craig, what about the SI joint? Where do you see that one referred to?
Oh boy, a lot to talk about with the old SI joint.
That joint is its own podcast too.
It's its own thing.
It's coming up.
So it's coming up. Stay for SI joint stuff because we have a lot to say about that one. The SI joint is tricky, and I think it's tricky because there is a lot of debate about it. I think like the low back stuff, we feel pretty good about it. The neck stuff, we feel pretty good about it. But I think there is so much variation, and such a difference in opinion on this SI stuff that we're gonna talk about it with a grain of salt. Some people says it moves, some people say it can't move. That's not the point. But with the SI thing, especially the big part is like groin stuff, genital area stuff. It can absolutely refer there. It could mimic like back pain. It could kind of mimic like buttock pain, or like everyone, piriformis syndrome. I hear that at least, a couple times a week. A little harder to tease out, but again, a lot of like sitting pain, sacral pain. I would say the tough part with this SI referral stuff is it typically can lead to pain that is tough, or people would consider embarrassing to talk about. I don't know if that's something you run into, but it's like when you get into those sensitive areas, like some people just like they don't want to talk about it.
Yeah. Yeah, I agree. And I heard you mention piriformis, and I will say that guy, that poor muscle, gets the blame for everything. Like that muscle is blamed for so much pain, by providers, by Dr. Google, by everybody. And I would say, I mean, how often do you think you actually see a true piriformis syndrome in the clinic?
Well, let's see. In 4 years
Yeah.
that I would consider I successfully treated, 2.
Yeah. I'd say probably between 2 and 4 that I've
That I
seen.
felt good about, that I could be like, yep, this is for sure it. Yeah, 2.
It just doesn't happen that often. A lot of times you can press on that muscle, and that muscle itself it'll be tender, as is tender in a lot of people. It gets overloaded, especially in athletes who are doing lots of squats and single leg work and runners. So it's pretty common for that to be tender. But is it being like the source of the pain or the cause of the problem? Oh man, it just doesn't happen that often. What about the knee? Or I'm sorry, the hip. What about the hip? Where's that referred to?
So I would say the big one with the hip, sometimes you can get a little knee pain with the hip. I would say like our spine stuff, way more obvious to refer out to like our peripheral area. The hip, a little rare, but you can absolutely get knee pain in the hip. I would say the big one, or at least the one that comes to my mind, is if you have some like obvious joint stuff going on, or like if you have a condition called like avascular necrosis, or something that is kind of crumbling that joint head into the socket, you can get obvious knee pain. It happens a lot in young kids, actually, believe it or not, where they can have a hip problem going on, and they come in with a little bit of hip pain, and they come in with knee pain as well. So I would say our differentiating tools there is hip pain. You can have some hip muscles that refer past the knee, but like hip joint pain sometimes can coincide with knee pain. Anything else you see with that one, or anything worth talking about with the hip? Because we kind of lump the hip, lumbar spine, SI. It's kind of like a big complex. When you talk about one, you kind of got to think about the other.
Yeah, I'm always assessing all 3 of them with every patient. I would say the hip, like you mentioned, true hip pain is usually right in the groin. People you make a C with their hand, and they'll put it like in their groin. They'll say this is where it hurts. It's actually referred to as like the C sign. So that's a pretty common one. And then it can refer down kind of the inner part of the thigh, and sometimes down into the knee. And since we're on the knee, I actually see a lot of like knee pain that is located in the back of the knee. And usually that's actually coming from the low back, or a tight nerve, or some sort of discomfort. Very rarely do I actually see that one coming from like the knee directly. So usually I'm treating something else when I see posterior knee pain. But I tend to find that that's been super common. A lot of people ask me about that when I'm doing injury screenings or mobility assessments. I see it a lot, where people can't bend their knee all the way back, or they can't straighten it all the way. And a lot of times they think that their meniscus is torn, or they think that they damaged a ligament in their knee, when actually it's just some nerve tightness, or a little bit of what we call like nerve tension. Do you see that one too?
Yeah, I would agree with you. I think that back of the knee pain, definitely a strange one. And I think it'll kind of hit on once we wrap up here. I think the detailedness of the assessment. And I think you talked about it earlier about like timing for practitioners to kind of do what we do. And I think that'll be, once we cover our last topic here, I think like when we talk takeaways and what to hopefully gain from listening to this episode, that'll be a huge part. But before we get into that, we always want to talk about our medical screening and always the serious stuff, because as patients, you absolutely have to be wary about it. And one of the more rare, but definitely not impossible referrals of pain are visceral referrals of pain. So I don't know, Drew, if you want to talk about that or just explain what does visceral referral pain mean?
So visceral referral is actually pain that comes from like an organ or a structure that is not considered muscle, tendon, ligament, bone. So if you're thinking about the things in your abdomen, your intestines, your appendix, your kidneys, your gallbladder, a lot of these can cause pain, and they can cause pain in different areas of the body, and they can mimic other things. So for example, I'll use the gallbladder as a starting point. In the right upper quadrant, so just below your ribs, you can have pain that shoots through to your back. Well, a lot of times people will mistake that pain as maybe being rib pain or some sort of thoracic pain, when actually, if you're eating maybe a fatty meal and you feel that flare up, we have a couple different tests that we can do to differentiate whether or not that could be a cause of the symptom. Another common one that I have actually experienced myself, I hate to say it, is kidney pain. Basically, that pain will refer to the back, so it can mimic almost like a disc herniation, but the kidney pain is actually a little bit higher up. So whereas most people would traditionally feel like a low back pain, where it's closer to maybe like the pelvis or the SI joint, and then it radiates and does different things from there. The kidney pain's a little bit higher up, and usually it's referred to as flank pain. So it's more in like the lower thoracic spine, and that is like a constant ache that just continues to grow and grow and grow and grow. It hurts really, really bad. So I hope none of the listeners ever have to experience that. If you guys want to hear a funny story about it, my experience at a CrossFit competition with kidney pain, feel free to reach out to me. I'll be happy to tell you. Craig, what other visceral referral patterns do you see or do you know of?
Yeah, I would say the ones I tend to look at, and you hit the abdomen really well.
Yeah.
Sometimes shoulder wise, like we talked about earlier, if you're having, cardiac, heart attack, even lung and diaphragm stuff can be left shoulder pain, or liver disease can be cause right shoulder pain. So again, really low on the list, but I think it kind of helps drive home the concepts we talked about earlier, in this common connection, and maybe things, not being what they initially seem right off the bat. So I would say, just because we're talking about it today, it doesn't mean everybody with shoulder pain has a liver problem, but it's absolutely possible, and it should be on everyone's differential list.
Yeah. I'd say two other ones worth noting are the appendix can cause pain in the right lower quadrant. We have different tests to help differentiate that. And another one that I've actually been seeing a lot more recently is patients coming in with hernias. That's another one where you can have an organ tissue kind of causing some pain. And you can have hernias in a number of different areas, like in the umbilical region, kind of by the belly button. You can have them down in the lower groin area. You can have them a little bit higher than that, more like in the side of the abdomen, but not quite in the groin area. So there's a number of different places to have organ pain referrals, and those aren't typically things that we are treating. Usually when we identify that there's some sort of organ pain referral, we are referring out to maybe a general surgeon or somebody that can take a look and determine whether or not this appendix needs removed or the gallbladder needs removed. Kidney pain, to prevent infection from going on, usually that's a trip to the ER, because if that kidney gets infected and then sepsis occurs, then you're in a really bad place. So usually when we identify some of this stuff in the clinic, we are sending patients out for further assessment depending on the severity and our findings.
Right. I think that's a great detailed response there, and I would agree with you 100%. So just wrapping up here, I think with the wrap up, I'd like to spend a little extra time, because I think it's important to talk about like what can you gain from this podcast, or what's like the take home point, or what's important here. And I think, Drew, earlier when you said that like your physician gets a short period of time with you, I think that's so important. So as physical therapists, we have the luxury of seeing our patients, whether it be 20, 30, 40, 60 minutes at a time, maybe one time a week, twice a week. What I'm trying to say here is we get to see our patients very frequently. Whereas if you go to your primary care doctor, if they're running behind that day, or even if they have their regular scheduled appointment, sometimes they schedule patients 15 minutes at a time. So
Yeah.
they have to do their charting before they see you. They have the medical assistant getting your vitals. By the time they get to you and they sit down and you say, my shoulder hurts, it hurts when I lift it up, it hurts right here. Okay, great, shoulder problem. Go see your physical therapist. We have the important task of kind of saying like, okay, let's try some shoulder stuff. Because a lot of time, if you have shoulder pain, it could be a shoulder problem. But if we get to see you long enough, we can go through a little more detailed assessment. We can see how things develop over time. And then we can start to notice, you know what? Maybe this isn't a shoulder problem. Maybe this is coming from the neck. We have the chance to go through that kind of like algorithmic, like step taking procedure. And I think the tough part is if someone in our position might say, you know what? I know your doctor said that this is a shoulder problem. I think it might be coming from the neck. And that doesn't mean that we're trying to like make any waves in the system, or we're saying one person is right, or we're saying one person is wrong. I think we just have the ability to, in some cases, be a little bit more detailed. And then it kind of comes to this point like, well, is the physical therapist right? Is my doctor right? Like it's tough because then the message can be a little bit mixed. And I don't think that's the fault of any practitioner out there. I think the medical system now has put pressure on people to make these like super quick decisions, and like physicians are expected to be right, 100% of the time kind of deal. And it's like, how are you able to be right when you have 15 minutes to look at, what could be something that's pretty complex? So I don't know if you have any thoughts on that, Drew, or if you have any other extra takeaways or something you'd like to add.
Yeah, I would say that if you feel like you haven't gotten a very detailed assessment, what I mean by detailed is, all these other areas of the body haven't been thoroughly examined for, typically my assessment, just to put into perspective, takes about a half hour to 45 minutes of me thoroughly pressing on all the areas I need to press and screening out all the different areas. And then we jump into maybe 15 minutes of treatment to finish out that particular visit or that assessment time. But usually there's a lot of work that needs to be done before you can jump to a spot and just begin treatment. And if you do your due diligence, then most of the time you can actually get to the root of the cause a lot faster without having to waste time going in the wrong direction. If your goal is if you meet a fork in the road and you have to choose one way or another, the ultimate goal is to choose the right way. So that you don't have to backtrack and go back the other direction. So that's what I'm always trying to do with my assessment. If you feel like you're not getting that, then I would highly recommend you finding somebody, another physical therapist or another provider, whoever it might be, that is going to give you that amount of time. You may not find it with physicians nowadays because they're so crunched for time with insurance, but there are providers out there who have the time and are willing to do that detailed of an assessment. With that being said, I wanted to say thank you guys so much for tuning into the Straight Talk Physio podcast. If you like what you're hearing, it would mean the world to us if you subscribe to this podcast and the Peak Physiotherapy and Performance YouTube channel. For more information about us, please check us out on Facebook at Peak Physiotherapy and Performance, on Instagram at P3 Physiotherapy. For more information about Craig, you can follow him at Dr. Craig G_PT on Twitter and Instagram. If you have any topic suggestions, comments, or questions, then feel free to email us at thestraighttalkphysiopodcast@gmail.com. Thanks again for watching, and we hope you guys have an awesome day.